Welcome back to the RASACS and Behind the Knife Journal Club on Landmark Papers in Surgery. I'm Shivani Bajpai, a general surgery resident from the Arundel Medical Center, and I will be briefly reviewing this Cochrane systematic review on ultrasound guidance versus anatomical landmarks for internal jugular vein catheterization. Central venous catheters serve an essential role in healthcare, providing a durable and effective route of access for pressors, chemotherapy, nutrition, dialysis, and more. The internal jugular vein is a common insertion site for central lines. Before the widespread use and availability of ultrasound, central lines were placed using the landmark puncture technique, using anatomical orientation to assist in identifying the internal jugular vein. This method relies on ideal conditions: conventional anatomy, body habitus, hemodynamics, technical experience, and carries a complication rate of up to 40%. Alternatively, using ultrasound guidance for central line insertion allows the operator to visualize the target, make controlled adjustments, and confirm placement, theoretically reducing the risk of complications. The purpose of this review is to collect the existing data on central line placement techniques and assess the efficacy and safety outcomes of both line placement techniques. Randomized controlled trials and controlled clinical trials were included in this study. Both children and adults were included, and there were no inclusion restrictions based on the demographics, comorbidities, or the clinical setting in which the line was placed. The primary outcome was the total number of perioperative and postoperative complications and adverse events. 35 studies were ultimately included in this analysis, which included about 5,100 patients. The results of this review showed that the use of two-dimensional ultrasound decreased the rate of total complications overall by 71%, decreased the number of participants with an inadvertent arterial puncture by 72%, decreased time to successful cannulation by about 30 seconds, increased the chance of success at the first attempt by 57%, and decreased the chance of hematoma formation overall by about 73%. Overall success rates were modestly increased in all groups combined at 12%. The number of attempts needed for successful cannulation was decreased overall. As in any study, there were some limitations to this review, including the quality of the evidence being very low or low for most of the outcomes and moderate at best for some of the other outcomes. Experience is also an important component of central line placement, and this review did not discriminate between those with less experience or more. More than half of the studies reviewed were older than 15 years from the time of this review. None of the studies addressed the impact of ultrasound guidance on mortality, length of hospital stay, or patient-reported outcomes, including pain or discomfort, and whether the infection rate is increased by the use of ultrasonic use or if the number of required puncture attempts is reduced was investigated by none of the reviewed studies and remains unanswered. Again, I'm Shivani Bajpai, a general surgery resident at the Arundel Medical Center. If you have any questions or comments, you can reach me by email. And please review the content in this week in SCORE modules on ultrasound use for intravascular access. Thanks for listening.